Welcome.
Thank you, Don. I think I have to say good afternoon. Well, today I will present about the radiographer's viewpoint on how to implement the new recommendation for the gonad shielding. And well, the argument the previous speakers already mentioned about that include the use of gonadal and fetal shielding can negatively affect the efficacy of the exam, and gonadal and fetal shielding provide negligible or no benefit to patient health. Well, there are some key points that I want to point out. There are position statements from professional organizations that we have seen today, and gonadal fetal contact shielding, plain radiography, CT, or what. If you look at different recommendations and guidelines, there seems to be along the way, like similar way, but in fact, the details are still we need to harmonize so that practitioners like radiographers we can follow, because at the end a final contact between the patient and radiographers are very important before the procedures. And when we look back at our radiographic practice, this is legacy practice. It's been years and decades that we have been doing this. And finally, I will talk about how to move forward with evidence-based scientific research. Well, here are all the recommendations and guidelines that has been published. I will not go through all of these, but among radiography research community, we have really taken a look into this issue for quite some time, and this paper was published back in 2014. This is about gonad shielding in pediatric pelvic radiography, effectiveness, and practice. So this is pretty much the retrospective study, and evidence of inadequate shield, lack of adequate protection found more in female patients, incorrect shield position lead to retakes, and the finding is in line with another study. So at the end, this study suggests that gonad shielding is no longer appropriate optimization tool for the female pediatric patient. This is just an example that my profession we have done in terms of research into our practice. Well, the story started when the American Association of Physicists in Medicine, AAPM, was very first organization to issue a position statement, the use of patient gonadal and fetal shielding, and it was later supported by the American College of Radiology. It caused a hiccup already a bit in the US, because I think this is a matter of communication, and later on the US NCRP issued this recommendation. But if you look at this recommendation, it mainly focused on gonad shielding in abdominal and pelvic exam, and this has a similar rationale as what AAPM has said. Well, if you look at the European consensus of patient contact shielding, very detailed on what you do in which exam, and this is pretty good guideline in my opinion. But as international organization for radiographers, we represent 94 professional societies from 80 countries all around the world. We look at different guidelines, and somehow we have to look into how to harmonize them, how to give information to our members across the world on how to do this. So ISRRT again finally issued the statement consistent with the commitment to culture of radiation safety. The ISRRT has decided to discontinue the shielding of abdominal and pelvic imaging when the exam is performed by registered radiologic technologists. This is what happened in the US. The International Society of Radiographers and Radiological Technologists, as I said, we represent more than 500,000 radiographers and technologists worldwide. In August 2021, we published this position statement, and we disseminate this to our 94 member societies from around the world. The ISRRT endorsed the change in practice, which is based on latest scientific research and risk-benefit assessment. But key thing is, However, any change in practice must be consistent with any specific national and local legislative guidance, protocols, and procedures where medical imaging is employed. When the recommendation first started, we faced into the situation that in many places, legislation says that you have to do it. When you don't do it, then you come into to the situation that you don't want to be on. And the ISRRT also support the leading role that radiographers undertake the decision-making, application, and communication processes of this issue, particularly their foremost position in patient radiation dose optimization advocacy and public awareness regarding radiation dose. Because at the end, we are the final contact with the patient. Patient would ask us what to do. And believe me, now patient Google. So they know things, maybe the right or not right information. So here are a list of what we publish. We have rational views, benefits versus risks, and we talk about in-beam versus out-of-beam, radiographers' responsibility, and so on. But one thing I want to point out, which is very, very important, is training in communication with patient. As I said, we are the final contact with the patient. We need to train our people on how to communicate the risk-benefit to the patient on why or why not we do the shooting for them. This is very interesting publication back in 2018. We take a look at questionnaire study of radiography educator opinions about patient-led shielding during digital projection radiography. There are three key areas: general agreement, generally neutral, and generally disagreement. You see, even among the educators, we still need a harmonized recommendation on how we teach our students. This is very, very important. And I think because the patient examination, not only one profession involved, this is multidisciplinary. The key point is we need to communicate among us what is best for our patient. So in practice for the radiographers and technologists, we look at patient-centric and science. We do science too. And for patient-centric, practice is not just science, but also how we provide best care to our patient. This is very important. And patients still concerned about risks of getting cancer from radiation, and this needs communication. Like Professor Donald Fresh talked about questions that we may get, like why you shoot the mother or the father, why, and you don't shoot the children when they get the x-rays. And we need, what we need to look at also is how to establish a new practice that involves patients' opinions and concern. All the time we talk about us, profession, radiologists, medical physicists, and radiographers. It's time we talk about our patient too. Science is fact, and fact is science. Evidence-based data show that minimum impact of patient dose from shooting. We know that. And dose has been significantly reduced by the advanced imaging technology. We also know that. But the point is, how can we implement this into the practice and harmoniously practice all around the world as the perspective of the ISRRT? So I would end my talk today with the way forward. At the end, the legacy practice of gonad and shooting practice will be discontinued. We know this is going to be the fact. And we need to put focus on our training for the next generation radiographers to understand pros and cons of the shooting. But how are we going to do that without the harmonious recommendation and guidelines? And especially for the educators like me, when I teach my students, we need a proper guideline, established guidelines. And not only the next generation, we as existing practitioners, radiographers, continuing professional development, CPD courses need to be conducted so that we can catch up with the up-to-date knowledge. And we also need to focus on the role of the profession to provide best care to our patient. This is patient-centric. This is not only the science, it's also the art of the practice, art of communication to our patient. And we believe that more research can be done in regards to the patient responses to the change. Previous speaker also talked about this. We need to involve the patient group when we want to change the practice that affect them too. And we do believe in the world of science, but we also do art of patient care when we practice with our patient. So this needs to be balanced. We can't deny the fact, science is the fact, but the point is, how can we implement this? The point is, how can we successfully implement this change of practice? So this is from us, the International Society of Radiographers and Radiological Technologists, ISRRT. Thank you.
Thank you, Professor PONGNAPANG.